Yeah, so I think the commensal microbiota has become a really interesting aspect of cancer immunotherapy and efficacy of checkpoint blockade. A couple of years ago, our own laboratory and another group found that in animal models, if you just change the composition of the microbiota, you could have either a strong or a weak anti-tumor immune response, and either a strongly or weakly efficacy of anti-PD-1 or PD-L1 therapy in mice. So this was very provocative. We could even find that if you identify certain bacteria, you could transfer them into mice that had poor microbiota and improve efficacy in vivo. And this would be super exciting if you could do it in patients, because then maybe you could develop a probiotic to give to patients and improve outcome if it were true in humans. So in the past couple of years, then, we've accumulated enough, believe it or not, stool samples from patients getting anti-PD-1 therapy, and we were able to sequence the bacteria in the stool and link it to clinical outcome. And what we found was that, yes, indeed, there are specific bacteria, if they're present in the patients, that marks clinical response to anti-PD-1, and patients who have the bad microbiota, who lack those good bacteria, are non-responders, and it splits patients very well. Now that this is validated in patients, we think that we can identify the specific bacteria, isolate them through special culture techniques, or even take similar bacteria that are available, identify their biologic activity, and encapsulate them and sort of create a probiotic that you could give as a therapy. So that's sort of the direction moving forward.